Hi, my name's Matt Brown. I'm Senior Survey Manager at the Centre for Longitudinal Studies, and I'm going to talk to you about the impact that COVID has had on data collection in the CLS cohorts. So, at the Centre for Longitudinal Studies, we run 4 national cohort studies which aim to follow participants throughout their lives. Our oldest cohort is the National Child Development Study, where participants are now in their early 60s. We have the 1970 British Cohort Study, or BCS70, where participants are now in their early 50s. Next Steps is following those born in 1990, and participants are in their early 30s, and our youngest cohort is the Millennium Cohort Study, who are now in their early 20s. So far, COVID has had a major impact on 3 of our planned surveys. As we all know, the pandemic really took off in March 2020, and at this point we were 3 months into fieldwork on the NCDS Age 62 survey, and took the decision to stop fieldwork just before government guidelines meant that we had to. In the case of BCS70, we just conducted a face-to-face pilot study of the Age 50 survey in February 2020, and we're making preparations to launch fieldwork in June, so had to delay. And in the case of Next Steps, we were due to start the development of the Age 32 survey, ready for launch in 2021, and again had to delay. So we obviously gave a lot of thought to how best to proceed. And in the case of NCDS and BCS70, there were really quite significant challenges to moving to a mixed mode approach, potentially involving web and telephone. So the questionnaire had already been fully programmed as a face-to-face survey, and NCDS fieldwork had already commenced, so this would have required major redevelopment. The questionnaires are also very long, 80 minutes plus, so potentially too long for web or telephone administration. Cognitive assessments are a vital aspect of both projects, and the assessments which we were running were designed for face-to-face administration. Both surveys collect data linkage consents, and we know that remote methods result in lower consent rates. Both surveys also involve the placement of paper self-completion questionnaires, which are typically collected by interviewers when they visit participants at home, and so we were worried about what effect this would have on completion rates if participants had to post them back themselves. And then finally, in the case of NCDS, in addition to the interview, there's a 60-minute nurse visit, which includes a range of health measurements, including the collection of whole blood samples, which are centrifuged in respondents' home, and there's clearly no way in which that can be done remotely. So we started to think quite a lot about video interviewing, as this approach seems to have a number of advantages. So people have obviously become increasingly familiar with video calling in recent times. This approach would mean that we wouldn't need to do any major reprogramming, so that was a major advantage. We know that long-term participants in our studies often appreciate the human interaction with an interviewer, and a video approach would at least retain that to some extent. We would expect there to be fewer measurement differences compared to moving to web or telephone-based data collection, and we felt that the video approach could work quite nicely in tandem with face-to-face when face-to-face interviewing could recommence, offering flexibility for respondents and allowing us to react to future changes in restrictions. So working with Kantar and NatSen, we conducted a couple of pilot studies. Firstly, a small-scale feasibility test, which we conducted with a skewed sample of 60 BCS70 participants, who we felt were slightly more likely to agree to taking part in this way. The feasibility test was quite successful, and so we followed that with a larger scale pilot of a representative sample of 310 NCDS participants in June 2021. We had to make a number of adaptations to the interview to make it suitable for video administration. We had to reformat some of the visual content, such as the leaflets and show cards, to make them suitable for presentation via screen sharing. Both interviews involve a self-completion section, which involves the most sensitive questions. So in a face-to-face interview, the interviewer would pass the respondent their laptop so that they can complete the questions in private. Obviously, that can't be done on video. So we programmed that section as a web survey, provided a link to it during the interview via the chat function, and asked participants to complete that web survey during the call. The cognitive assessments were a little challenging, or one in particular. 3 of the 4 are conducted orally, so they're fine really to do via video, but the 4th is done on paper. So we had to post this task to participants, but it's a timed task and also relies on them not seeing the task beforehand. So we had to send it in a sealed envelope and ask participants not to open the envelope in advance of their interview, and the interviewer was to check that during the call. And then the paper self-completion questionnaires, obviously we had to ask participants to return these via post. So how did it go? Well, on this slide, I'm comparing the outcomes of the video pilot with the outcomes of the first wave of face-to-face fieldwork, which was conducted in January to March 2020. And you can see in that wave, we achieved a 79% response rate. So we achieved a 46% response rate with a video-only approach, and it was a fully video-only approach. So it wasn't just the interview that was conducted remotely, but there was no door knocking involved. All of the contact was remote via telephone or email. So we were actually very pleased with this. And we had a further 25% of cases saying that they would be willing to take part, but they'd rather do so via face-to-face, and so would prefer to wait until that was possible. There was quite a significant impact on the completion of the sensitive self-completion section. So normally we'd expect almost everyone to do this, but when asked to do it via web, we only got around 80% of people completing it. There was no impact on completion of the cognitive assessments in general, with the exception of the task that had to be done on paper. So there we got a 94% completion rate, which we were pretty happy with, but it had to be returned in order to be scored. And so we ended up only conducting that assessment with, well, only having information about the assessment for 83% of participants. And there was a similar impact on return rates of the paper self-completion questionnaire. But there was no impact on data linkage consent rates, and there was no impact on agreement to be visited by a nurse. And interviewers and respondents alike were both positive about the experience of taking part in this way. And despite the length of the interview, over 80 minutes, the interviewers reported high levels of engagement from participants throughout, and break-offs were very rare. So we then conducted a larger scale soft launch of the video-only approach with just over 1,000 BCS70 participants between July and October 21. The results were quite similar to the NCDS pilot, though the response rate was a little higher at 52%. And then in November, we launched main stage fieldwork for both projects with a video-only approach, and the indications are that similar response rates will be achieved. The next waves of fieldwork will be commencing imminently, and our plan was that this would be the point at which we relaunch face-to-face, but unfortunately, in light of Omicron, this is not going to be feasible, so these waves will again be conducted video only. And then the following waves are due to commence in April, so we hope that face-to-face interviewing will be feasible to launch at that point, but time will tell, of course. Non-respondents from the video waves will also be reallocated to face-to-face interviewers when that's possible. We relaunched our nurse visits in NCDS in November, and these have been continuing to be conducted. And it's, as I said, it's not possible to conduct these remotely. So moving on to the Next Steps Age 32 survey, where we're working with Ipsos Mori. So we had planned that this would be conducted as a face-to-face survey, but we've switched to a mixed mode approach in light of COVID, and that's a bit more feasible in Next Steps compared to NCDS and BCS70. Firstly, because prior sweeps of Next Steps have been conducted mixed mode. The interview's also shorter at 60 minutes. And also at the point at which the pandemic hit, we were at a much earlier stage of development. So it was all a bit more feasible to do this. In 2021, we piloted the data collection instruments using a full variety of modes. So via web, video, various different ways of conducting the interview via telephone. And we also trialed a secondary device approach where interviewers would knock on the door, provide participants with a tablet on which they could complete the interview, and then return an hour or so later to collect the device. We are now planning to launch fieldwork for Next Steps in late February. We'll be using a web push sequential mixed mode design, so participants will first be asked to complete via web, and then non-respondents will be allocated to face-to-face interviewers. This will take place in April. So again, as I mentioned earlier, we're hoping that face-to-face in-home interviewing will be feasible by then, but we'll see. And if not, then the face-to-face interviewers will offer video and secondary device as an alternative. And then possibly we'll be doing a telephone mop-up phase with a potentially abbreviated version of the questionnaire. In the case of MCS, the next week, the Age 22 survey is going to launch in early 2023, and at the moment we're planning that will be conducted face-to-face. We're currently in the development phase. We're working with Ipsos Mori, and we will be ensuring that flexibility to switch modes is designed in from the outset. So to wrap up, I'm just going to summarize some of the key challenges that we're facing. So although remote interviewing is proving to be quite successful and achieving 50% response rates via video in NCDS and BCS70 is encouraging, particularly as I mentioned, to date, this has been achieved by fully remote contact with no door knocking. But to achieve the high response rates typically achieved in the cohorts, face-to-face interviewing will be crucial, and the continuing uncertainty about when this will be possible makes planning very difficult. The longer term impacts of the pandemic are somewhat unclear at the moment, so we don't really know whether there's going to be an impact on people's willingness to participate, but we hope that by offering flexibility with regards to mode, that this risk will be mitigated, but time will tell. Interviewer capacity is certainly a challenge, so the agencies that we're working with have lost interviewers over the course of the pandemic, and not all of the interviewers that they currently have are willing to restart making home visits, and there's also a lot of demand from the many surveys which have been postponed. So this is definitely a challenge that we're going to be facing in the coming year. Survey timescales are definitely at risk too, particularly if face-to-face interviewing can't restart in the fairly near future. And just to conclude, I think possibly the key learning point for us is, as I mentioned with regard to MCS, just how important it is to design flexibility in from the outset, so that going forward we're able to nimbly adapt to whatever circumstances might be thrown at us. Thank you.